الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. لنا إلا ما أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما يا كريم. This is the last venous imaging. We'll deal with imaging of the peripheral veins as well as the imaging of the IVC and superior vein. These are the items we will to handle. First, the anatomy, superior vena cava obstruction, and many issues about the IVC. We'll finish with the veins post syndrome as well as Trenauri syndrome. IVC we will also discuss, inshallah. This is just one of the techniques that are performed in the area of venous imaging for the development of MR venography and CT venography. Used to find the IVC through putting the the upper limb sides and cave, of course, as you particularly, and this is just an example you can see here a map of the mediastinum the flow in the left arm as well as in the right arm, specifically the superior that is the most common cause of superior vena cava obstruction is malignancy, especially the bronchocarcinoma and the lymphomas. One of the issues nowadays is the catheters, thrombosis and as well the pacemaker wires, and this issue is the fibrosing mediastinitis, aneurysm, and of course the basic disease which can cause superior vena cava obstruction, also IVC obstruction. The clinical presentation of superior vena cava obstruction represents and depends on the speed and the severity of but facial flushing, bilateral signs, medic and cough. And this is the imaging findings. In the plain film we see some widening of the superior mediastinum, prominence of the right hilar is just mediastinum. Then by CT you can verify the existence of the mass, and you can see the filling or the non-pulsing core of the superior vena cava presenting the thrombus. Remember that in cases of vascular venous thrombosis, the wall of the vein is usually enhancing due to its blood through the thrombus. Because of the obstruction, you may got lateral venous along the chest wall, the vena cava as well. And this is the central bronchocarcinoma invading the mediastinum, totally infiltrating the vena cava. Here is the region of the vena cava which is really involved by tumor mass, and also as in case the right pulmonary artery and the presence of considerable pleural effusion on the right side and effusion on the left side. And this is based on a thrombus, which would be thrombus by many imaging characteristics, and number the tumor thrombus will expand, the tumor thrombus will contrast material, the tumor thrombus will show metabolic activity in cases of the able to extend outside the vein, invading the adjacent structures. All these differences between the malignant or and the regular thrombus. This is the tumor thrombus. It expands the IC and shows a post-contrast enhancement. And this patient is known to have metastatic esophageal cancer. Is a state in regular thrombosis. This is not a malignant thrombus. You may see some metastatic lymph nodes in the mediastinum. You see as well. This is what we call iatrogenic obstruction, and it was achieved because of the repeated central line or central venous catheters. The venous line initiates trauma, infection, thrombosis and occlusion of the superior cava. And this is one of the cases in a patient with end-stage renal failure, and there are multiple central venous catheters used for hemodialysis, resulting in total occlusion of the superior cava with extensive dilation of the mediastinum. One of the ways to treat this condition is to put it within the superior cava in condition after central venous catheter, resulting in fibrosis and occlusion of the superior cava. This condition was treated by placement of a stent superior cava. This condition is cellular proliferation of collagen and fibrous tissue within the mediastinum, and it may appear about 20% of cases, or in most cases it will appear as a focal type and may sometimes mimic a malignant lesion. In many cases it cannot and it typically presents among others, but can affect any age group. These are the suspected causes of idiopathic is seen in most of the cases. However, some of the conditions and the thoracic malignancy contribute to this condition. The findings on imaging is that the soft tissue mass mediastinum classically goes into calcification. Then if you inject a contrast, the mass will show a hardness pattern enhancement, and then fibrosis may encroach on the bronchi, may compromise the vasculature as well. And here you see in the plain film, you can see the reformatted a big mass in the mediastinum. That's and this is the actual image. You see the mass is increasing in the bronchus, and also significant narrowing of the pulmonary artery closely, and this was identified in the scan with the diminished perfusion to vascular compromise of its blood supply. The second topic in the lecture too many ways, including the ultrasound, CT, MRI, and phenogram. In the same way, we perform superior vena cavography. We also put the peripheral contrast material on both sides, and we let the contrast medium opacify the inferior vena cava. But the in a space after injecting an adequate amount of material scan in the range of 80 seconds after the injection of contrast injection, then you go to opacification of the IVC. There are some important issues about the IVC, considering the presence of double IVC, and this is very important whenever you course to place a filter because of even thrombosis within the IVC, and you should be aware about if the IVC is single or double. The MRI is one of the reliable techniques if you want to discriminate between the regular thrombus and the during the previously mentioned issues about thrombosis of the metal anomalies of IVC are rare, and in most of dramatic. In the imaging, you cannot see the IVC sometimes because of the and the azygous continuation. They will mention they may got prominence of the collateral veins, especially around the lumbar spine, and patients may present by lower extremity deficiency or signs of deep vein thrombosis. This web is a rare anomaly which may be in form of complete or fenestrated membrane in the hepatic portion of the IVC or just above the portion of the IVC, and this may lead to congenital Budd-Chiari syndrome because of the venous outflow from the liver. Congenital Budd-Chiari to the development of hepatocellular carcinoma later on. The alternatives for venous of the limbs is that the IVC is occluded by a tumor. We have the azygous system, the hemiazygous, the accessory hemiazygous, as well as the superior intercostal vein. And you can see here that the azygous vein is formed mainly by the right ascending lumbar vein, and some of the intercostal veins it will drain into the superior vena cava approximately of the dorsal. Then the azygous vein is formed mainly by the left ascending lumbar vein, and some of the intercostals it will join the azygous vein at the level of the 8th dorsal vertebra. The azygous drains the upper limb, the upper side of the left side of the body. It will join also the azygous vein and here is the azygous vein, which is formed by the right ascending lumbar vein and the right side vein at the level of the number 12. It will go through the diaphragmatic nerves and it will join the superior vena cava at the level of the dorsal. And the azygous vein drains the right lower 8 posterior intercostal and the right superior intercostal vein. So the azygous vein will receive the hemiazygous and the accessory hemiazygous veins. from the ascending lumbar and left posterior intercostal, it will join the azygos vein, dorsal vertebra number 8. The hemiazygos vein drains the superior left thorax, and it is formed by the 4th to the 8th left posterior intercostal vein, the left bronchial vein, esophageal veins, and joins the vein at the level of the number 7. This is a contrasted CT scan of the course of the hemiazygos, the azygos vein, while it is arching at the level of the dorsal vertebra number 5 posterior vena cava, and this is the right side of the IVC interruption and for continuation of the IVC segment above the level by the azygos or hemiazygos vein can be seen usually in clinical practice. And one of the easiest ways to differentiate between azygos continuation or hemiazygos continuation is to look at the position of the vein in relation to the aorta. And this is the aorta, and you cannot see the IVC because it is interrupted and it is continuated. If the vein is to the right side of the aorta, this is the azygos continuation. If the vein is to the left side of the aorta, this is the azygos continuation, which is less commonly seen in the clinical practice. And here you see that the azygos vein is huge, extremely dilated, and compensate for the damage and it joins the superior vena cava. And this is to an azygos continuation of the interrupted IVC, and here is the aorta, and the is to the right, while the part of the directly directed, and this is the publication of the that you have another IVC on the left side of the main IVC, and this left IVC will remain in all cases into the left renal vein and will go directly after. One of the important remarks here, whenever you are going to do and it should be that there is no depression of the IVC. And this is easy by CT. Here's the aorta, and you got two venous channels on both sides. This is the original IVC, and this is the left-sided one. And here also you can appreciate, and you can do the coronal reconstructed images to see the left IVC go to the left renal vein, then to the original IVC after that. There may be also a left-sided inferior vena cava, and the original IVC crosses the left side of the aorta. It will join the left vein and go to the right side, continuing at the IVC after that. Be appreciated by contrasting its reconstruction. This is the aorta, this is the left-sided IVC, course of the normal IVC after that. Behind the IVC, impedance of the and some dysplasia in the cell system, which may initiate or infection and calculi formation. And there is an infection known as circumcavilator, where the ureter is coursing around the IVC, and here in the three sections the ureter posterior to the IVC, and to the left of the IVC, and ureter anterior to the IVC, meaning that it is a circumcavilator. Also, you may find circumaortic, the cross posterior anterior to the aorta, that whenever you have the reconstructed images, and you can see this course of the renal vein in relation to the aorta. Also, one of the important issues to be reported in cases who are donated the kidney, and they perform usually pre-operative renal angiogram. They should specify if the renal vein of the donated kidney left is crossing behind the aorta or anterior to the aorta. And in this case, you can see aortic left renal. IVC tumors, myosarcoma of the vascular system is represents about 1% of malignancy, and it accounts for about 57% of the tumors of the veins. Then leiomyosarcoma commonly in women between the 50 to 60 years, and as I mentioned before, the tumors and the vein, the tumors will enhance with material, the tumor thrombus will extend outside the vein and invade the surroundings. Then the prognosis depends on the segment that has been affected by the tumor. The tumor affects the renal part of the IVC, this is the most prognosis. While if it is affected the intrahepatic segment, this is the worst prognosis. In this case, the endogenously enhancing soft tissue mass into various directions, and in the view show almost total occlusion of the IVC. This is the myosarcoma of the IVC. This is the IVC, which is expanded, being involved by enhancing soft tissue presenting leiomyosarcoma. And in this case, you may need to complete resection of the IVC this the overall survival rate is about 40%, and in 50% you get recurrent disease. Also invaded by tumors from the organs, commonly the renal cell carcinoma, and the kidney through the renal vein to the IVC, the tumor to go through the renal vein and then into the vena cava, and the tumor may reach the right atrium as well, and this will affect the staging of the tumor, also the prognosis of the lesion. And this is the case with carcinoma extensively with the renal vein and the IVC, as well as it has very invasive thrombosis. Also, the adrenocortical carcinoma, especially the right-sided tumor very near to the IVC, may invade the IVC by tumor thrombus, having the same characteristics as of the tumor. And this is the bilateral adrenocortical carcinoma with the IVC, and so a case of bilateral adrenocortical carcinoma invasion of the vena cava. This is the aorta, and this is the whole of the right kidney. This is the adrenal gland on the right side, and this is the left side. When this tumor of the pediatric age group has an incidence of 6% in invasion of the is the case tumor with retroperitoneal lymphadenopathy, invasion of the IVC, and hepatic metastatic deposits. Also, the IVC can be invaded in about 7% of the cases with non-seminomatous testicular tumors. And you should also know that the metastatic peritoneal lymph nodes the IVC. And if the tumor to go to the IVC, it will cause tumor thrombus. There are lymph nodes, malignant lymph nodes with IVC nodes may invade the IVC. The aortic fistula has two main etiologies, which is less common, and the which is more common. In about 85% of the aortic fistula, the underlying cause is aortic aneurysm that has eroded the wall of the IVC and the between both vessels. While of the case, there is a history that has initiated fistula between the aortic and are possible, but are. And if you have the physical study, the abdomen, got the and you see simultaneous opacification of the water and IVC at the same time, you should predict that some way of fistulous communication between both vessels. And then if you go lower down, then you will see that there is an aortic aneurysm that has eroded the IVC and resulted in the formation of this fistulous communication. And this is another example where you see the evaluation of the IVC and the hepatic veins. Lower down, you got a big secular aneurysm with the fistulous communication between the patent lumen of the aneurysm and the adjacent IVC. Then the IVC thrombosis is like any vascular thrombosis in the body. It has many risk factors, including the hypercoagulability, pregnancy, pregnancies, and the local compression of the IVC by lymph nodes or masses. IVC filters it thrombosis and thrombus, regular thrombus, sending into both directions, up and down. And the difference is more between malignant thrombus and bland thrombus. The bland thrombus do not expand the lumen of the vessel. The bland thrombus do not enhance. The bland thrombus do not extend outside the vascular lumen. The bland thrombus has characteristic signal intensities on MRI imaging, signal T1 and T2 being made of acute blood. And this is an example of extensive thrombosis of the IVC. Able to notice the enhancement of the IVC, and there is significant expansion of the vessel, and no enhancement of the thrombus inside the vein. Then the thrombus IVC may be calcified, and this is, according to the literature, seen primarily in children, and it is considered and these are the causes: abdominal malignancy, adrenal hemorrhage, coagulopathy, and the concurrent infection. And this is coronal relief image of calcified thrombus within the IVC. IVC filters are needed to prevent the showers of E. coli coming from the lower to reach the circulation. These are the placement of inferior vena cava filter. Number one, contraindication to coagulation, as in cases of gastrointestinal bleeding and recent neurosurgical procedure. Then if you are using anticoagulants but there is pulmonary emboli coming to the lung, and you put this filter, or with anticoagulant treatment, and large iliocaval floating thrombus. This is very important. If the thrombus is floating and you can see by Doppler, it should prevent this thrombus from reaching the pulmonary circulation. Then you put the IVC and you ensure the correct of the filter. These are the contraindications. Number one, complete vena cava thrombosis, you cannot the filter. If the field vena cava is too small or too large to admit the filter, or cases of the presence of infection, and this is also a contraindication. If you put the filter, these are some of the complications that are expected: bleeding from the side of the filter migration up and down, and vena cava injury, vena cava thrombosis, and also the presence of pulmonary emboli in spite of the presence of the filter. Then we came to the assessment of the lower limb veins, which can be evaluated by many techniques, including the ascending venography, descending venography, Doppler ultrasound, CT venography, and eye venography. The regular venogram was performed previously, inserting a peripheral cannula in veins and applying a tourniquet above the ankle and another tourniquet below the knee to prevent the flow of material into the superficial venous system. And you know that the calf vessels are three: anterior tibial, perineal, and the posterior tibial arteries. Each of these arteries is accompanied by two venous channels. Six venous channels in leg, and they are bleeding, as you can see, because of too many valves within the system preventing the retrograde flow. After the leg vein, the is good, which will continue as femoral vein, receiving the deep femoral vein to form the common femoral vein. The notification literature form superficial femoral vein should never be used, as the femoral vein is in fact a deep vein. Because here the superficial vein is the saphenous, is called the saphenous vein. Then this is one of the ways previously used to assess the competence of the saphenofemoral junction. You insert a needle in the common femoral vein, and you inject the contrast material while the patient is performing the Valsalva maneuver, and you take another film while the patient is taking a deep breath. Then if the veins are competent, then you should not see retrograde flow of contrast material beyond a distance of about 2 to 3 centimeter. And if you see that there is reflux of the contrast material lower down in the limb, this means that you got incompetent femoral vein. And many times we may use the venogram to assess patients with suspected pulmonary embolism, and we inject contrast material intravenously to assess the pulmonary vascularity. Meanwhile, we can use the injected contrast material to assess the lower limb veins, putting into consideration that the deep vein thrombosis in the lower limbs is the most common factor contributing to pulmonary emboli. Then if you scan the lower limbs at that time, after scanning the lung for the presence of pulmonary emboli, and you may see filling defects within the veins of the lower limb indicative of deep vein thrombosis. And here you can also reconstruct the images to have this coronal reconstruction, and see extensive venous thrombosis of most of the femoral vein as well as the popliteal vein. And also you can follow the thrombus intra-abdominally to see the affection of the left common iliac as well as the IVC. And one of the alternative ways, if you cannot inject the patient with contrast material used for CT because of the hypersensitivity to this contrast material, you can use gadolinium and do the MR venography by the same way. You put a cannula in the peripheral vein of the left side and right side, and you inject simultaneously the contrast material, and they scan the lower limbs by MRI, and you may have an MR angiogram, arteriogram, and you may have a venogram after that, and you subtract both from each other, and you got the arteriogram, single arteriogram, and the venogram as well. Then this is the normal venogram of the thigh on both sides, and this is a case with deep vein thrombosis with superficial varicosities, and you can see which that are too extensive on the left side. The deep vein thrombosis is one of the well-known diseases in the medical practice, and many of the deep vein thrombosis are occult and resolve spontaneously without complications, but sometimes the deep vein thrombosis may be associated with massive pulmonary embolism leading to death. And the symptoms of deep vein thrombosis include edema, which is considered the most specific symptom, and leg pain, which is seen in about 50% of the cases and is non-specific, tenderness, warmth, and erythema of the skin over the areas of thrombosis, and the clinical symptoms of the presence of pulmonary embolism like acute chest pain, hemoptysis, and so on. You should know that about 50% of patients with classic symptoms have negative venogram, and about 50% of patients with venous thrombosis lack the specific symptoms. And these are the risk factors for the venous thrombosis, and there are too many, and you should remember the immobilization, the hospitalization, surgery, trauma, hypercoagulable state, and the smoking, and the prolonged travel, which is known as the economy class syndrome. Then the appearance of deep vein thrombosis on venogram will be like this, and you see multiple filling defects within the affected veins, what looks like the tram track sign, or the thrombus may cause abrupt venous occlusion or partial venous occlusion leading to the formation of the meniscus sign. Then if you see here, you can appreciate the extensive worm-like filling defects within the deep venous system, indicating deep venous thrombosis. The complications include the recurrence, the formation of post-thrombotic syndrome, the paradoxical emboli, and 40% of the patients will have pulmonary embolism. And one of the complications is the post-thrombotic syndrome, which will appear in the form of symptoms and signs of chronic venous insufficiency after the treatment of deep vein thrombosis. This syndrome is the sequelae of reflux due to valvular incompetence and venous hypertension due to thrombotic occlusion. The symptoms and signs include pain and edema, varicose veins, skin pigmentation, and this very resilient issue, which is venous ulcer. Then what do we mean by post-thrombotic or post-phlebitic manifestations? And these are: number one, irregular intraluminal filling defects; number two, which is very important, destruction of the valves; number three, multiple incompetent perforators leading to opacification of the superficial venous system. These are known as post-thrombotic manifestations. Then we finally came to the Klippel-Trenaunay syndrome, which is a triad of port-wine nevus and bone and soft tissue hypertrophy, meaning that there is local gigantism, varicose veins, and venous malformation of unusual distribution. This disease is rare, and this is the incidence, and is often unilateral, affecting one of the limbs. And here you can see the relative enlargement of the limb compared to the opposite side, the classic port-wine nevus, and you see the varicosities, and also by imaging you can see multiple dilated vascular venous channels in the affected limb. And if you compare the caliber of the limb to the opposite limb, you get enlargement of the limb. Then soft tissue hypertrophy, and you may also appreciate the presence of superficial varicosities without the presence of deep vein thrombosis. Also in the plain film and CT you can see calcified fibrillary in the veins due to the stagnant flow. And this is MRI and MR venography of a case of Klippel-Trenaunay syndrome on the left side, and you may also appreciate that there are little changes in the opposite limb as well. And this is right-sided Klippel-Trenaunay syndrome. You see the varicosities, you see the calcified fibrillary, you see the significant enlargement of the limb compared to the opposite normal side. Thank you very much. Alhamdulillahi Rabbil Alameen.